This is Darren here. I'm one of the nephrologists from Melbourne. I've been given the task to cover transplantation in 60 minutes, so I'll see how I go. Okay, so I hope you actually received the questions from yesterday, and we'll go through some of the choices and see what you think. So today I would like to cover firstly maintenance immunosuppression, followed by living kidney donor candidate assessment, particularly the concept of lifetime end-stage kidney disease estimation. Then we'll talk a bit about incompatible pairs, and finally something on deceased donor kidney offers. And I actually asked quite a few trainers what they would like to cover, and it seems like it would be good to cover some areas where you don't get a lot of exposure to during your training. And some of these answers basically is not absolutely right or wrong, and very often there's a lot of uncertainty. And I just would like to go through some approaches and principles for you to take home with. Okay, so the first question, so it's case number 1. So this is a 42-year-old builder with end-stage kidney disease, secondary to IgA nephropathy, and he lives in the Sunshine State. He's now 12 months post-transplant. The HLA matching, basically, it was all 6 out of 6 mismatch. No pre-transplant donor-specific antibodies. In fact, he had no antibodies at all. His creatinine was pretty good, 105, no proteinuria, clean biopsies at 3 and 12 months. He's on the pretty standard immunosuppression tag, mycophenolate and prednisolone. He does have quite variable tag levels recently on the same dose between 3 and 8. He had a pre-transplant squamous cell carcinoma, a skin cancer, and then about 2 months ago, so that was post-transplant, he was noted to have another SCC on the face, which was completely excised. There's a bit of debate whether someone should actually test for de novo donor-specific antibody. Anyway, it was performed at 12 months, and it was negative. So what should we do next? Okay, so the choices, and there would be 2 most appropriate choices and 3 of them not appropriate. So the first one is to reinforce the importance of sun protection and start nicotinamide 500 milligrams BD. B is to switch from mycophenolate to azathioprine to reduce the overall immunosuppression, which should reduce further skin cancers. C, soft tacrolimus to preserve the long-term graft function from the risk of CNI nephrotoxicity, and also to reduce the new skin cancer occurrence, as his immunological risk is quite low. D, to switch from TAC to everolimus, which is an mTOR inhibitor, to reduce the new skin cancers without any risk to his graft because his immunological risk is low. And E, high tacrolimus level variability would increase his risk of premature graft loss long term, especially with his HLA mismatch profile. So if you could type in your choices, that would be good.
They're coming through now. I'll start allocating them to you.
Okay, thanks.
Can you see the little grey question panel come up in your control pane?
I'll see whether I can expand it. Hang on. You can only see one at a time, isn't it? Or you can see more.
No, they should all be coming through now. I've allocated them all to you.
Okay. 1 second.
Can you see them all there?
Yep. I just need to scroll it down, but that's fine. So I think most people pick A, D, and E. So the correct answers were A and E, and D is not incorrect, except the statement about without any risk to the graft. There's always some uncertainty, and there's always a risk to rejection when you switch. Doesn't mean it's not correct to switch, but there is a risk to the graft. So I thought I'd just go through this because it is often said to be the holy grail in kidney transplantation, how low you can run immunosuppression and without causing rejection. So you can see this diagram from a recent review on de novo donor-specific antibodies and HLA matching. If you run immunosuppression high enough, eventually you run into problems, and it would increase the risk of infection, and in this case, skin cancers. And in fact, the type of skin cancer he's got at the moment on the face is one of those higher risk SCC. So in the worst case scenario, and the most common cause of death from cancer in Australia is still squamous cell carcinoma. So that would certainly be a reason to change your immunosuppression in some way. The risk of CNI toxicity causing graft loss is probably not, it's a little bit overestimated from previous studies, and this is probably thought to be less important nowadays. And in fact, most of the graft losses, apart from death from graft function, death with graft function is actually immunological due to chronic rejection. So in this case, he's got virtually no HLA matching. And if you reduce immunosuppression, there's a risk that you might develop either clinical or subclinical T-cell mediated rejection, either because you asked him to do this or he's non-adherent, as sort of highlighted by his TAC level variability. That's sometimes a suggestion someone is not very adherent to their medications. Or in fact, just with the current tools that we have for immunosuppression, regardless of what dose you run them at, perhaps eventually they will still develop chronic rejection anyway. So eventually you develop chronic graft loss due to chronic rejection. So even though at the moment he is immunologically quiescent, it doesn't mean that when you reduce his immunosuppression or modify it, it won't cause rejection down the track, particularly in his case due to the poor HLA mismatching. So the reason why we've been pretty much the last 10 years using low-dose TAC, mycophenolate, prednisolone, and basilizumab as induction as a standard of care is because of the Symphony study that was published in 2007, so that was 10 years ago. And the proposed target for TAC level was 3 to 7, and the mycophenolate starting dose was 1 gram BD. And you can see that for the biopsy proven acute rejection rate was the lowest with low-dose TAC. They have the best graft survival, and they have the best GFR as well. So it all sounds quite good. But when you read studies on immunosuppression, it's always good to see what target levels and doses they actually achieve or they actually had during the study. So even though the target TAC level was 3 to 7, what was achieved in the first 12 months was somewhere between 4 to 9. So running a mean or median TAC level about 6.4 at 12 months, and similarly hasn't really changed even at 3 years. With the mycophenolate dose, most patients had it reduced to 1.5 grams as the daily dose, so about 750 BD, and by 3 years further down, somewhere between 500 to 750 BD by then. So exactly how low you can go is still not quite clear, whether you can still do TAC level 3 to 7 without causing problems, because the actual achieved TAC levels were actually higher than that. So this is a study showing that, and it is all retrospective, they combined 4 randomized controlled trials, and some of those actually, they were steroid withdrawal trials. So you just have to be a bit careful when you interpret the findings. But anyway, what they found was for those with TAC levels less than 4, they had a much higher risk of rejection compared with those running between 4 to 8 or 8, higher than 8. It doesn't seem like there's any additional benefit to run anything higher than 8. And what we don't know is whether it's safe or unsafe to run lower TAC levels beyond 12 months. That's the uncertainty. And it seems like it's not just low TAC levels. If the levels are very variable, as in this case with this gentleman, even with the same mean trough level of 6.8 versus 7.1, the patients with high variability, they seem to do worse and more likely to lose their grafts compared with those with low variability. And perhaps if you have high variability and you have low TAC levels, and in this study less than 5, it seems to be synergistic to be associated with worse graft loss. This is a study which the problem with this study, I guess, again, is it's a steroid-free regimen, which is not very commonly used in Australia. But in America, where they do a lot of steroid-free regimen, so what they did was at 4 months, they randomized patients to run their TAC level between 7 and 12, and those to run at TAC level just about 3. And you can see that after the randomization, there was a separation in the achieved TAC levels. And those running at low TAC levels, they actually had what the Symphony study was trying to achieve, which was about 3 to 7. And what happened was there was a higher rejection rate compared with those running at a high TAC level. And they also had higher incidence of de novo donor-specific antibodies. What we don't know is that whether it applies to those on steroid-containing regimen, which is what we use as triple therapy. This is an interesting study, and basically what they tried to do was to pick the ones like our patient where we thought was low immunological risk. And at 6 months, they randomized to continuing TAC, mycophenolate, and penicillin versus versus to withdraw the tacrolimus over about 3 to 6 months. And more than half of these patients either developed T-cell mediated rejection or or de novo donor-specific antibodies. And it seems like the patients who had a high DQ mismatch would be at higher risk of rejection or forming donor-specific antibodies. So this is a study from a couple of years ago, and it was relatively interesting because what they did was they found patients and they gave them some pill bottles and boxes, and it's monitored electronically. So if they don't open the bottle at specified times, it would be recorded. So they could stratify those who were non-adherent versus those who were adherent in the first 2 months. And what happened was those patients who were not adherent, and if they also had poor DR mismatches, and particularly poor DQ mismatches, they were more likely to have rejection and had an inferior allograft survival. And so perhaps, I mean, you shouldn't tell your patients if they have good matching to don't worry about taking the immunosuppression, but perhaps these people could get away with it with slightly poor adherence, and perhaps these are the patients we could minimize immunosuppression more safely. And then the next question, which is one of the choices in the answers out of the 5, was what about switching CNI to mTOR? So this is a meta-analysis, and it shows that either converting it early or late, you get better GFR, but perhaps the better GFR is because those on CNI had lower GFR due to the hemodynamic effect of CNI. It's a bit like you put someone on an ACE inhibitor, and if you stop it, the GFR gets a bit better anyway. So it's probably not so much to do with chronic damage, but more just the hemodynamic effect. However, the problem with mTOR, and there are many problems, and that's why we don't use it a lot, they do get more rejection. They're more likely to develop de novo donor-specific antibody, and later on antibody-mediated rejection. And this is a retrospective registry data from America, and basically it showed that those on mTOR inhibitors, they were more likely to die earlier and to have earlier graft losses. So bearing in mind it's retrospective, but it does raise some questions about whether someone should ever be on an mTOR inhibitor. And perhaps the only reason why you would put someone on an mTOR inhibitor instead of leaving them on a CNI is to reduce the risk of skin cancer. So for both this study from France and also one from Queensland, those patients with previous SCCs who switched to mTOR, in this case sirolimus, compared with those staying on a CNI, they had a lower risk of further skin cancers. It is not zero, because you can see that in the Queensland study, half of those eventually still got a skin cancer despite being on mTOR. Perhaps there could be the best of both worlds regimen. And what this TRANSFORM study, some of you might have been involved in your hospitals, where they examine and compare running mTOR, in this case everolimus, with reduced CNI dose and steroid versus the standard Symphony type regimen, which is the most commonly used at the moment, and see whether you could still have this similar rejection rate, no higher rate of donor-specific antibody formation or worse graft outcome, similar EGFR, and but you can still get the benefit of lower skin cancer rate. That would be the best situation, and that probably would take a few years before we know the outcome from this study. Nicotinamide is a vitamin B supplement, if you like, but it might be too good to be true. But in non-transplant population, published a couple of years ago in the New England Journal, there was an RCT showing that those who were randomized to take nicotinamide had a lower risk of SCC further down the track. But once you stop it, there is no legacy effect, so you have to keep taking it, basically. There hasn't been a finished RCT on transplant population, but as a case control study, there did appear to be a lower risk of SCC for those who went on to nicotinamide. And sometimes just free sunscreen actually works. So maybe not for the builder, because you probably won't put it on, but in this study, what they did was they randomized some patients to receive free sunscreen, and you can see this group had a lower risk of skin cancers in the next 2 years compared with those who did not get the free sunscreen. On the right, because there was an answer about whether to switch from mycophenolate to azathioprine, and in fact, if anything, you might be worse off by doing that. There is a theory azathioprine might sensitize the skin to UV radiation, and the metabolized 6-TG might actually be mutagenic. This is not completely proven, I think, and this is retrospective. There might be a lot of confounders, but at least this meta-analysis would suggest that those on azathioprine might actually be higher risk for skin cancers. Whether you would switch someone already on azathioprine with skin cancers to mycophenolate, for example, that's quite controversial. Some clinicians would do that. So does anyone have any questions first before I move on to case number 2? Otherwise, we'll leave all the questions to the end, if that's okay. All right, so case number 2, this is to illustrate, I guess, the new concept of lifetime end-stage kidney disease risk estimate for the living kidney donor candidate. So this is a 55-year-old man with near end-stage kidney disease secondary to IgA. His blood group B, he's got no antibodies, never had a blood transfusion. His wife is 53, but she's got insulin requiring type 2 diabetes, and basically would make her unsuitable as a living kidney donor. He's one of the lucky men with 2 living kidney donor candidates coming forward. One of them is a 63-year-old sister. The other one is a 32-year-old son. So the sister is ABO incompatible, but HLA identical, and you've got about a 25% chance of that from a sibling. And the 32-year-old son is ABO compatible because his blood group O, he's got the typical haplotype match with the father. They are both ex-smokers. The son, however, only stopped smoking 3 months ago, whereas the sister stopped smoking 30 years ago. They had the same BMI of 29, no diabetes. Both had the same blood pressure of 120/70. but the sister had hypertension for 3 years, but seemed to be quite well controlled on the 24-hour ambulatory blood pressure monitor. And the echo showed no left ventricular hypertrophy as a possible end organ damage from hypertension. The sister had a lower GFR of 85, and both of them had similar nuclear GFR. And the urine ACR was within the normal range at 1.0 milligrams per millimole, and both of them did not have hematuria. So the questions were, which one of these statements would be the most appropriate? So A, the son is the preferred living kidney donor candidate because he's free of any comorbidities and he should have a lower lifetime risk of end-stage kidney disease compared with the sister with hypertension. B, the sister is the preferred living kidney donor candidate because she has a lower lifetime risk of end-stage kidney disease. Or C, the sister should be informed that her end-stage kidney disease risk is likely higher post-donation, but her actual risk should still be quite low during her lifetime. D, the son is the only ABO-compatible donor candidate, and although the patient is unwilling to accept the kidney from his son, which is quite a common scenario, but we should convince the patient that about the benefits of the son donating to him. Or E, as the patient is unwilling to accept a kidney from the son and the sister is ABO incompatible, so his long-term outcome would be better just to be placed on the deceased donor waiting list after starting dialysis. So could you put in some of your answers and see what the consensus might be, please? Oh, Vanessa?
They're all coming through to you. Can you see them?
I think so. C and D. C and B, A and C. So most people picked C. There were some D's, some B's, and some A's. Okay. Thank you.
Why is my thing?
All right. So I thought the most appropriate answers were B and C. D is a bit controversial, and I'll explain. I mean, it's not totally incorrect, but one of the problems with living kidney donation is the recipient needs to be happy to accept the gift. You could convince the father, but whether it's the right thing to do is a bit controversial. And A is incorrect, and I'll explain why, because of the age difference between the sister and the son. So, lifetime end-stage kidney disease risk is generally higher and more difficult to predict in younger living kidney donors. The son, basically for young donor candidates, they might look very good now, but you just don't know what's going to happen in the next 50 years or so. And he's already a bit overweight. He's got a family history of type 2 diabetes, which was relatively early onset from the mum. And on average, the risk in kidney donors actually quite low, and it's actually lower than the unselected general population, because you generally wouldn't allow someone to donate a kidney if they were going to be high risk. So they're quite highly selected generally. But comparing with those who are also as healthy, the risk is actually higher, and it would sort of make sense because you remove about 30% of your reserve for your lifetime, so the potential risk the actual absolute risk is actually quite low for most people. What is not known is for the younger donors, like this gentleman, 32-year-old, you can't really say the same to say it is going to be very low. And for living kidney donation to proceed, you basically need three parties to accept the situation. So you need the donor to be informed of the risk, and hopefully it's a more precise and specific risk for informed consent. And it needs to be happening without coercion. That's very important. And the recipient needs to be happy to accept the gift. So in this case, the father seems to be quite unwilling, and it is for good reason as well, as I'll show later. And the last thing, and probably the most controversial sometimes, is for the transplant center to accept that the risk is acceptable. And if you decline a living kidney donor candidate because of your concern with the risk to proceed, and the candidate is very keen to proceed, then you should always offer a second opinion somewhere else. And in general, the recipient's outcome is superior compared with a deceased donor kidney transplant. And if you can do it preemptive, and generally that's the only way, at least in Australia and most states, to do this, that's better than starting dialysis and going onto the waiting list, which could be a few years. And at least in Victoria, for blood group B, it's usually about 4 years or so, if not longer, for someone not sensitised. And ABO incompatible transplant is no longer a reason not to accept a kidney donor, because if the recipient's got very high titers, then they can go into the exchange program. If they have quite acceptable titers, then in fact, if they've got very low titers, some centres would actually not remove any antibodies. But if they've got low to moderate, you have antibody removal, you start the mycophenolate 1 to 2 weeks earlier. But otherwise, quite standard immunosuppression, and had equivalent outcomes in the last probably 5 to 10 years. It's not very commonly used in terms of rituximab in Australia. It's more commonly used overseas, and perhaps not super important for this patient, but for a younger patient, if you have a HLA identical donor, it does help to minimize immunosuppression down the track if you need to, and also for your second graft, you don't get too broadly sensitized. This is a study, actually a review paper from this year, and basically summarized 2 landmark studies on the risk of end-stage kidney disease in living kidney donors. The problem with all these studies, well, not many, but is that the follow-up usually is relatively short. For the donors to develop end-stage kidney disease. You can see for this American study, the median follow-up was only 8 years, and usually it takes like 20 to 40 years at least to develop end-stage kidney disease after kidney donation, because for someone to proceed initially, the risk shouldn't be unacceptable or too high. So it takes time for kidney disease and end-stage particularly to develop in donors. The absolute risk is quite low, and the relative risk is quite hard to confirm, because it depends on the control group. If the control group is too low risk, obviously the relative risk is high, and perhaps 8 to 11 times is a bit too high. Now it's probably considered to be somewhere between 3 to 5 times compared with not donating. But that cannot be definitively confirmed either. So in this American study from 3 years ago, you can see that the living kidney donors had an end-stage kidney disease risk at the age of 80, which was about 0.9%, and that's including African Americans, and traditionally they're at higher risk for end-stage kidney disease with or without donation. Their risk is high compared with the healthy non-donors, but lower than the unscreened, unselected non-donor population. And yeah, we've just mentioned about the short follow-up being the problem. So in fact, whether this is basically extrapolated from follow-up up to 15 years. So it's very hard to predict exactly, over about 50 years or so for the 32-year-old, what his risk will be post-kidney donation. So this is a study showing the risk of end-stage kidney disease following kidney donation, and the median risk was 0.34% at 20 years. So for that guy, age 32, you're only going as far as 52 years of age, and he might as well develop kidney failure after that. And if someone's risk is at the 99th percentile, it doesn't make sense to tell that kidney donor candidate that his or her risk is 0.34% at 20 years, when his or her risk is actually 2.56%. The problem we have is we don't have very good tools to determine what that actual absolute risk will be for the candidate. So this group of researchers developed a risk calculator for living kidney donor candidates in terms of the risk of end-stage kidney disease. So they used large cohorts, median follow-up 4 to 16 years, and they got a calculator which you can go to the website and just put in your 10 variables, and that would give you a 15-year risk and a lifetime risk. The problem with this is that it's only the risk estimate without donation. So what the risk is post-donation is unclear. You can multiply 3 to 5 times and give the approximate risk to your donor candidates, but it hasn't really been confirmed or proven. The reason why they did this was because if you want a risk calculator for kidney donors post-donation, the event rate for kidney disease end stage is going to be too low, and you need to follow them up for too long, and there's just not going to be enough numbers for you to actually develop a calculator. So that's another way to get around it, because if someone's baseline risk without donation is high, you would imagine post-donation the risk should be similarly high, and it's a way to risk stratify for your donor candidates. The limitation for this is obviously if you have a risk factor like in this gentleman, the family history of diabetes, that's not captured, then you might underestimate the actual risk. It's not very precise for young living kidney donor candidates because you just don't know what's going to happen in the next 50 years. And for those being obese, you might, again, underestimate your risk of kidney failure post-donation. So I think this graph is helpful to grasp the concept of lifetime risk. Perhaps don't worry about the African Americans because we don't have them here, but for the Caucasians, men and women, you have a much higher risk lifetime of kidney failure post with or without donation compared with the older ones. So if you just look at the 15-year risk, they would have the lowest risk, and that's quite predictable because kidney failure generally it does not occur in young people unless you've got some relatively uncommon kidney disease. So most end-stage kidney disease causes post-donation would be due to hypertension and diabetes, and these diseases generally do not develop during the young age groups. So if you look at these two kidney donor candidates, the sister had a higher 15-year risk compared with the son, but the lifetime risk, despite the hypertension on treatment with a lower GFR, is actually lower compared with the son, who is actually estimated to be more than 1% without donation. So if you have to pick one who is considered to be lower risk during the lifetime for kidney failure, it's actually safer with the sister. So why do you actually want to have living kidney donors if there is a risk to the kidney to the kidney donors? And that's because they do much better compared with the deceased donor kidney transplants for graft survival and also for patient survival. And this is particularly the case for the older recipients where they already have some comorbidities that would put them at high risk. And if you have a living kidney donor, your risk compared with dialysis would pretty much flip in favor of transplantation soon after the surgery. Whereas if you have a standard or even worse expanded criteria donor, an elderly with comorbidities, your risk would be higher at the start, and it will take longer for you to benefit compared with dialysis. The other benefit of a living kidney donor is because you can do this preemptively before you need to start dialysis, or at least minimize the time on dialysis, because the longer time you spend on dialysis, the worse you do in terms of patient survival. Okay, so I'll go on to the third case. I'm probably running behind a little bit. So this is on incompatible pair. So this is a 58-year-old lady with near-end-stage kidney disease from reflux, blood group O, the anti-A, anti-B titers, which I'll explain why they're there later on, would be considered acceptable and amenable to antibody removal. And this is by diamet. You probably would have different types of titering method at your local unit. So she basically was sensitized from her 2 previous pregnancies, and if you use an MFI threshold of 2,000, the calculated PRA, which is the panel reactive antibody, would be 71%. So you've got antibodies which you consider unacceptable against 71% of your donor pools. If you use a lower MFI threshold just to be safer, then you would be about 82%. So the husband's come forward as a donor candidate, blood group O, and 4F6 mismatch, and the peak serum, so the one with the highest MFI for your donor-specific antibodies. So he's got 4 of them, and the highest MFI against A1 was 7,320. But the CDC and flow cross-match for both T and B cells were negative. So I guess which of the following would be appropriate? So should we just prepare her for dialysis because they're not compatible and it's going to be too high risk to do it? Should we go straight preemptively with the kidney from the husband because the cross-match was negative and the DSA is unlikely going to be clinically relevant? Put them in the exchange program and to look for a lower immunological risk donor and exclude any DSAs with MFI more than 2,000, and perhaps have some form of desensitization therapy to further reduce the risk, or D, just don't accept any MFI for any of the DSAs, just exclude them all, but put them in the program. Or E, if you accept an ABO incompatible donor for the exchange program, that might improve her chance of a successful HLA compatible match. So any answers?
There's been a question come through as well from Mia. If you just want to have a look in the question pane.
Yep. Why do patients with blood group B wait longer if we can perform ABO incompatible transplants? It's a bit different for deceased donor and living donors, because for living kidney donors, you can remove antibodies for 1 or 2 weeks until you're happy with the titers before you proceed. Whereas for deceased donor, they need to be low enough baseline titers for you to do it basically upfront with perhaps without any plasma exchange, or just with one before you go to theatre. So it has been done, but not everyone will have a low enough baseline titers to accept an incompatible option. And they still get allocated to the blood group A, for example, instead of straight to the blood group B, if that makes sense. Okay, so C and E, B and C, C and E, C and E, C, C, C and E. So mainly C and E. Yep. Okay, so very good. That's what I would choose. Okay, and I'll just put up a slightly different case, the same sort of theme. So what if you have a 35-year-old lady, so a younger person? This time calculated PRA was a lot higher, 99.6%, doesn't matter what threshold you use. And this is the mum who's got a bit better matching, blood group compatible, and only one DSA, and it's a CW, and it's a lower MFI. Again, cross-match negative. So would you put her on dialysis and just wait for a deceased donor because the risk is too high, and perhaps you'll get a lower immunological risk donor from the waiting list? Or B, just go straight ahead with the mum, and because her PRA is too high to get any chance in the AKX program? Or C, do put her in the exchange program and exclude the DSAs with MFI more than 2,000 and try for 1 or 2 runs, and if you don't get anything, then go to plan B. Or D, again, just like the previous case, exclude all DSAs, doesn't matter what MFI, until you find a matched donor. Or E, the Luminix, so the solid phase assays are good enough nowadays that if you don't find a DSA in these broadly sensitized patients, then you shouldn't have any other DSAs apart from the CW that was mentioned. So B and C, C, B, C, B. Thank you. And B, and more Bs. Yep. So for me, I think either B or C would be not unreasonable, and it's a bit of, I guess, preferences from the pairs and perhaps the nephrologist. And I think the key is if you pick C, you just be prepared to go to B, soon instead of waiting forever, because the chance of getting a match is quite low in the AKX program for someone that's sensitized. So the differences between the two. So lower PRA, you get a better chance of a match. And for the last case, it's actually unlikely you're going to get a better deal in the exchange program, but I guess you never know. So the first case got a high MFI, and it was a multiple. It was 4 DSAs instead of just 1. So you would think it's high risk to go direct. And probably quite importantly, it's not just about whether you've got DSAs and how many and what MFI. If you have DSAs against your husband and you're sensitized from the pregnancy with that husband, it is much more likely they're going to be pathogenic. So you're a lot more worried about it. If you want to take away one message from today about Luminix for antibodies, it's got a lot of limitations, and if you can't detect an antibody, it doesn't always mean that it's not there. So if someone's got no DSAs but broadly sensitized, they can still get very bad antibody-mediated rejection early on. So I think of it as whether you're likely going to get a match and how high the risk is. So your risk depends on whether it's cross-match positive and how strong your DSA is. And the match probability depends on your calculated PRA. So if your PRA is high, it's hard to match. So if you're hard to match and you're easy and relatively low risk to go ahead, then you probably just go straight ahead with or without desensitization of some sort. If you're hard to match, you're easy to match, but you're high immunological risk, then you would want to go into the AKX. Or if you're both hard to match but also high risk, then what you might want to do is go into exchange program and find someone low risk but still with some risk. And as long as you find it acceptable, because sometimes life is not perfect. So if you're not going to accept any FFI in the exchange program, in a broadly sensitized patients, you're probably going to be wasting your time, because you're almost never going to find a match. And the risk is more calculated compared with going on to deceased donor waiting list, because you can do a flow cross match, which you don't get from the deceased donor. You get high resolution molecular typing, so you know whether the DSA is definitely donor specific or not. You can desensitize is a dirty term, but you can do some sort of manipulation at the start to try to reduce the early risk of rejection. And because from a living donor, generally you don't have delayed graft function, so it's much easier to monitor for rejection if the creatine's not following you. You've got a much lower threshold to biopsy someone. The ABO incompatible option has been shown in Australia to really make a difference to increase the match rates, because in an exchange program you tend to deplete the O donors and you accumulate the O recipients if you don't do the ABO incompatible option. I might skip that in the interest of time. And basically, in AKX, you see that the very sensitized patients, and in this case, the PRA 97% plus, particularly for the O recipients, they've got a much lower chance of a match within, I think, after 3 years, that's right. So, and you start to accumulate these broadly sensitized patients. They're very hard to match. And this is a study showing that in the AKX program, you tend to deplete the O donors and you accumulate the O recipients. So if you're not going to accept an ABO incompatible option for some of these patients broadly sensitized, you're probably going to be very difficult to find an O donor. And I think this is a good sort of very simplified risk stratification where if you're CDC cross-match positive, you're very high risk to reject. If you're just flow cross-match, it's a bit lower. If you just have DSA but negative cross-match, doesn't mean you've got no risk, but it is lower than a flow cross-match or CDC cross-match being positive. And if you have none of those, then your risk is relatively low, but it's not zero. And another thing to take home today is, which I'm sure you know, and you should have read Bill Marley's review paper from nephrology a few years ago. So if you have a T-cell cross-match, because class 1 antigens only are expressed in all nucleated cells, if you have a T-cell cross-match being positive, it's a class 1 antibody, whereas a B-cell cross-match being positive could be either class 2 or 1. So if you have a T and B-cell cross-match being positive, it could be class 1 plus or minus 2. If you just have a B-cell cross-match being positive, then you could be a class 2 or a weak class 1 that is not enough to cause a positive T-cell cross-match. Or if you have a positive T-cell cross-match but negative B-cell cross-match, something is wrong and it shouldn't happen, basically. There's something technical that has gone wrong. In the interest of time, I might just sort of try to flick through some of these slides, but basically it's saying that if you have no DSA, no positive cross-match, this is your risk of graft loss, and the risk increases incrementally depending on whether you're just DSA positive or flow cross-match positive or CDC cross-match positive. The next question is, what about comparing with staying on dialysis for a hopefully compatible deceased donor kidney? And if you're just DSA positive, this is in America, comparing with staying on dialysis, you do much better just to go straight ahead with your living donor against which you've got a DSA. Still a little bit better for CDC positive cross-match, but obviously some of these patients die from complications from your immunosuppression. What is different is that I think for transplantation, it's always good to look outside America sometimes because they just have different patient survival for both dialysis and transplantation, particularly for dialysis, because in this UK study, and the difference also is because they only included those with at least flow cross-match being positive, so not just the DSA and negative cross-match. So the risk would be a bit higher. But nevertheless, you find that those broadly sensitized patients actually had very good survival on dialysis up until 8 years, just down to about 80% compared with about 50% in the US. And as a result, they actually did not have a survival benefit by going with the patients who was the donor who was HLA incompatible. I might flick through this in the interest of time. And just to say that for Luminix, there are a lot of potential limitations, and it's not black and white. Probably the main thing is when you call it positive, do you use a specific MFI threshold? Some people use 1,000, some people use 500. Perhaps it's different for different types of HLA antigens. Maybe CW and DP, they're not expressed on the donor cells as much, and perhaps a high MFI would be acceptable comparing with the other HLA antigens. So this is probably an important concept to get through, and when you look at your Luminix report with heaps of antibodies, it might not mean they are all different antibodies. And what's happened is antibody is directed against an epitope on a HLA antigen. So, for example, HLA1 antigen in this case, just all made up. It's got 4 different epitopes. And this epitope is shared with the other 3. So if you develop an antibody against this epitope, on your Luminix panel, you would get antibodies against HLA 1, 2, and 3. Doesn't mean they are 3 different antibodies, but that's just the way it's picked up on Luminix. I might skip that. So I'll go through the last 2 cases. So this is about diseased donor kidney offer. Hopefully you've read some of these, so I can just run through it pretty quickly. So he's a 57-year-old guy, and he unfortunately had early graft loss due to technical issues. So within days, had a transplant nephrectomy. And it was actually quite fortunate for him at the time that, if you can call it fortunate, he had no A mismatches and no DR mismatches. And he had 2 HLA-B mismatches, so they were 51 and 61. He was basically stuck on nocturnal home hemodialysis, never got a kidney office until very recently. So his blood group A, he's broadly sensitized, despite only 2 HLA mismatches against the HLA-B. So he got a national allocation kidney offer. He was a young donor, brain death, good kidney function. KDPI was 9%, so it was a low percentage. And the only HLA mismatch out of 6 was A3. CDC cross-match for T-cell was negative. Didn't get any B-cell CDC cross-match, and as usual, there's no flow cross-match. So against this A3 mismatch, there was a so-called weak antibody. And he had a potential DSA against what is called B2708, and this MFI is considered quite strong. But when you actually get the offer, sometimes can be quite confusing, where it's against B27 and it's a subtype based on molecular typing. There was 08. So if you look at the serological typing, it was B27, with a DSA against this, but he's actually B27 himself, so it's actually against a self-antigen. But obviously he would be a different molecular typing. It's just that we don't know what that is, and we can't confirm from the donor what B27 molecular typing would be at the time, because we don't have the high resolution typing at the time of the offer. But what was helpful was the tissue typist beforehand realized that there was an issue to report this as an antibody when he himself is 27. And basically it was noted that for this to be the donor would usually be BW6, and in this case, the donor is BW4. So making that quite unlikely it was a true DSA. It's a bit complicated, but just say that there's some uncertainty. So with the following, would you say you should decline this offer because the KDPI is too low, the donor quality is too bad, or the T-cell cross-match is negative, but it doesn't really help you to risk stratify the DSA against A3 or the potential DSA against B2708? You should decline this offer. C is the other choice because the patient's already rank 1 and it's got adequate dialysis waiting time for another offer very soon. After confirming with a senior tissue typing scientist that the chance of the donor being this molecular typing where you've got an antibody against is quite unlikely, and then you would accept this offer because the patient is broadly sensitized and very unlikely going to get anything better than this. And E, the low MFI DSA against A3, especially without flow cross-match, does not necessarily confirm that he's not going to be at risk of antibody-mediated rejection.
I've got 2 questions that have come in as well, so I'll just submit those while the other ones come through.
Yep. So what would you consider a significant NFI? And the second question was ABO incompatible versus HLA. What is worse? So second question is probably easier. ABO incompatible, unless you've got very high baseline titers that you try to cross, the outcome is better than you having a pre-transplant, I guess, donor-specific antibody, particularly if it is cross-match positive. The ABO issue is mainly for your early graft survival. So if you've got a very high titer that you can't get it down, or despite getting down, your risk is really in the first few weeks, usually in the first few 1 or 2 weeks. Whereas HLA, you have the early risk and you also get the longer term risk as well. So unless it's very high baseline titers, it's better to go ABO incompatible in the living kidney donor setting. And what would you consider high MFR? Most people would consider maybe somewhere like over 8,000 something. Most people would feel, and usually would translate into a positive cross match anyway. Usually around 4,000 plus, people start to worry about it, but it depends. There's no magical number, and sometimes you might get a DSA and MFI about 3,500. No blood transfusion, no pregnancy, no previous transplant, and you didn't do any plasma exchange, and there's no antibody-mediated rejection. So that's why it's difficult. There's no magical number. Generally, very high is probably not a good idea. Very low is not zero risk, but sometimes in life it's somewhere in between when you get the offer. So answers, I've got D, E, B, D, and E, B, D, and E, D, D, E, C, E, D, 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 and E. Yes, so D and E would be the appropriate answers. C, the problem is that this guy, even though he's got enough waiting time, he might never get a kidney that he would be compatible with. So, so that's not appropriate. And B, it does re-stratify to a certain extent, but not completely, because those 2 antibodies are class 1. Probably particularly helpful for the potential DSA that you've got. So low KDPI is actually good, means good donor quality, negative cross-match. So we've explained that. We've explained the low MFI is not zero risk, but it does give you some reassurance. It would be good if you have a flow cross-match that is negative, but we don't get it in disease and a kidney transplant setting. And as mentioned before, this guy is broadly sensitized. You're unlikely going to get another better offer. It might be a once-in-a-lifetime kidney offer, so you really want to think about it seriously before you say no to this offer. Okay, so the last, do I have a few minutes left, or am I running really over time?
No, that's okay. Continue. Okay, that's fine.
Sorry. Yep. So this is just a little bit modified compared with the first one, and just to illustrate a few points when you consider kidney offer. So this is a much younger person. He's been on dialysis for 3 years. He's blood group A, at least in Australia. It means that he's got enough dialysis waiting time to get the next offer. In fact, he's had several offers in the last few weeks. He's not sensitized. He's got immunity against hepatitis B from vaccination because the core antibody is negative, so it's not from past infection. This is state-based, but basically just saying 36 months of dialysis waiting time is ranked quite high. So he's got a kidney offer from a 60-year-old man, intracerebral hemorrhage, brain death pathway, terminal creatinine was 98. This donor's got type 2 diabetes, hypertension on treatment. His KDPI is 86%, so unlike the previous case that was 9%. No matching at all, as quite commonly the case for a dialysis waiting time offer. T cells, his cross-match was negative, no DSAs. There is a question whether this donor actually had melanoma 25 years ago. It was completely excised, no known recurrence, but you can't actually find the histopathology report from 25 years ago, as you would imagine. You can't really get good collateral history about his increased risk behaviour. But there was a question whether he might have been an ex-IV drug user, although he's now 60 years old. Perhaps as a result, his core antibody positive for Hep B, but surface antigen negative, hepatitis C and HIV antibody negative, and he was net negative for all three viruses. However, he's only 2 days into his admission, so there is a window period. So the questions were which one would be appropriate. So would you accept this offer because the KTPI is in the top 86%? B, decline this offer because the quality of the kidney is quite poor for a young recipient and you worry about early graft loss and being sensitized for retransplantation. And very likely he's going to get another offer fairly soon that should be better off, and he's not sensitized, so it shouldn't be too hard. Or C, decline this offer because the risk of hepatitis B transmission is too high, so the donor's got the core antibody positivity. D, accept this offer because the negative net excludes the risk of for donor transmission for blood-borne viruses, so that should be safe. Or E, decline this offer because the remote history of melanoma is still a concern for donor transmission, even though it was 25 years ago. So I've got B, B and E, B and E, B, B, A, D. B, A, B, B and E, B and E, B. All right, B and E. Great, and B. Seems like there's a consensus for B and perhaps E as well. So the answers were supposed to be B and E. So I'll just go through probably the issues and what you would consider when you get a kidney offer. One day it might be just next year or you're already getting offers anyway at the moment. So usually there's no right or wrong answer, but just some sort of basic principles. So a high KDPI is actually lower quality kidney. So, but sometimes it might be suitable for older recipients. And if it's 86%, it means the risk of graft failure at the 86th risk percentile compared with previous donors. So it's actually worse to be higher rather than lower. The younger recipient, in the second case, you generally would like a younger kidney if you can, because when you become sensitized when this graft fails, it might make it very difficult to get a second transplant as well. And they generally can put up with dialysis for a few more months for a better offer if you need to wait for a better offer. Dialysis waiting time, so it's already on the top of the list, so you can afford to wait a little bit. It hasn't got much to lose if you decline this one. Melanoma is sort of a traditionally bad term when you hear about kidney donor offers because the risk of donor transmission is always a concern, and if you do have a transmission, basically you die. So and I would say perhaps a lot of units would universally decline any donors with a history of melanoma. Doesn't matter how long ago it was, and that's because they have very poor outcomes historically. It is shown to be exacerbated by immunosuppression, and the proof of concept is the checkpoint inhibitors being effective for treatment. And there were some concerning features in this case. One of those is the intracellular hemorrhage, and it could be due to several metastases. And in fact, the fatal transmission cases in the past were perhaps mostly due to the unrecognized cerebral metastases presenting as intracellular hemorrhage. And if you can't define the risk of the melanoma from 25 years ago, it makes it more difficult to be comfortable, if you like. It was confirmed to be a female melanoma. It was excised many years ago, then the risk is probably quite low. The problem with this case is there was no risk to, or there's no point to risk it because it's a young donor, he's got enough dialysis waiting time, he's not sensitized. In terms of the Hep B transmission risk, it's actually very low for someone who's immune from a donor who was core antibody positive, but surface antigen negative and NAT negative. So that's not a reason to decline the kidney donor in this case. You can always offer lamivudine if someone's got no immunity, but you should do some post-transplant surveillance of some sort. The concern in this case is actually perhaps not very high, is whether this patient might have blood-borne virus infections that is not closed by the window period despite doing the NAT test. That is probably more of a concern than the core antibody being positive for hepatitis B. Hep C, nowadays you can probably eradicate it. Perhaps in the next couple of years we might not worry about it too much anymore. Hep B, if you've got immunity, the risk is not quite that high. The real concern for someone with potentially increased risk behaviour from the donors is really HIV because of the stigma, and also they generally do worse post-transplants being HIV positive. Again, for this young recipient, there's no point to risk it. So just to summarise, when you consider kidney offers, so you think about the donor issues and the recipient issues. Donor issues, the donor quality, you can go by KDPI. You can go by mainly just due to donor age anyway for the KDPI, the immunological risk and the risk of donor-derived events. When you consider recipient issues, you should think about the likely time the patient will need to wait further. Have they got enough dialysis waiting time? The age of the recipient, if they're younger, you probably want to wait for a better offer. For someone very sensitized, this might be a once-in-a-lifetime offer. You really want to consider that very carefully before you say no. And lastly, the HLA matching. If you see a score that's more than the dialysis waiting time, and usually it's because there's some sort of HLA matching, and very often it's an early offer, and you're better off to skip some dialysis waiting time and get that matching usually. So hopefully I've covered the learning objectives today. And do you have any burning questions?
I've got a few that have just come through. I'll allocate them to you now.
All right. So the first question I've got is the age difference to be acceptable between young recipient and O donor. To be honest, I don't know the absolute answer for that. Traditionally, it's been said to be about 30, but I think if you have, I don't know, if I was the recipient on the waiting list and I'm, say, 55-year-old and I've got enough dialysis waiting time, do I really want to take a kidney that's 70-year-old with a creatinine of like 100? Probably I would want to wait. I think that there are two issues here. One is you want to somehow utilise these older donors so that you don't have a waiting list that's going longer and longer. And like when I was training as a registrar, I remember the blood group O waiting time was about 7 or 8 years, whereas now it's more like 3.5, 4 years in Victoria. And part of that is because we've taken some of these more marginal offers. So that's sort of a more global sort of perspective. But if you have if you have an older recipient that's sort of fit enough to stand any risk early post-transplant from an older donor and still have an acceptable kidney function that doesn't need to last forever, and if they can skip some dialysis waiting time, so I guess if you have a 65-year-old diabetic, still pretty fit, and there is a 70-year-old donor and you can skip 12 months of waiting time, that wouldn't be a bad thing to do. And then the next question, how long are the NAT window period for Hep B and CHIV? So Hep C is about 3 to 7 days. HIV is about 7 to 10 days. Hep B is about 3 weeks. And the next question, what exactly is meant by doing a Luminix? How does it work? Yeah, sorry, I should have explained it a little bit better. So when you do a Luminix, basically you put your serum from the recipient against a panel of beads, which are quoted with the HLA antigen. So what you detect is what antibodies that HLA antibodies the recipient's got against particular HLA antigens, and then you look at the donor HLA typing to see whether these antibodies are donor specific. So, and to call something positive or negative, you have to set some sort of MFI of some sort. So some people use 500, some people use 1,000. But, it doesn't mean that, 501 is significant and 499 is not significant. It's not quite like that. You do look at what your self-antigen antibody and MFI would be, because you shouldn't develop an antibody against your own antigen, and that would be counted as a background. So it's not quite clear-cut. The way to work out the PRA is if you set whatever threshold of MFI to say it is significant, then any antibody with MFI above that is significant. Then you look at how many, the percentage of donors with these HLA antigens that you've got antibody against and how prevalent they are in the donor population, and that would work out your panel reactive antibody, Okay, next question, in which case you would switch from CNI to mTOR? Yeah, so I guess you never be certain whether you're going to run into problems, but I think that guy, for example, if he had better HLA matching, you'd probably be quite comfortable, or a lot more comfortable to do it, or someone older, because even if you get a de novo DSA, which is not sort of like causing bad rejection, you might lose a bit of graft time, but it might be much more important to make sure that person doesn't die from some cancer that would metastasize. Whereas for a young person, you're just a little bit more careful. So perhaps an older person, preferably a little bit better matching, and with high-risk skin cancers, particularly if it is recurrent. But you want to do it at some point where before it becomes locally advanced that there's a point of no return. What would be really nice is if the Transform study shows that it's got some benefit to reduce skin cancer risk without higher risk of rejection of formation of DSA de novo, then that might be the way to go in the future. But we don't have a lot of data yet about the mTOR with low-dose CNI but no anti-metabolite, whether that might be the best combination to do.
We've got one more question that's just come through.
Okay. Is switching to mTOR applicable to other cancers? Yep. So the main evidence is skin cancer, in fact, mainly SCC. You probably know for some cancers, like particularly renal cell carcinoma, the different type of mTOR inhibitor has been tried and has been shown to be effective. But perhaps as a big group, mTOR inhibitors tend to reduce the skin cancer risks, or at least associated with lower cancer risk. But the main one is SCC. If you're talking about breast cancer or prostate cancer, they tend not to be as affected by immunosuppression anyway. So, would you switch for like someone with a TCC of a bladder that's recurrent? If the immunological risk is very low, if you've got zero DR mismatch or something in someone older, you might. But it's really for someone with skin cancers, I think.
That concludes tonight's webinar. Thank you, Dr. Lee, for such a great talk.
Okay, thank you.